Sure. So my name is Katie Eilers, and you can see my picture and a picture of my family there. I am a public health nurse, and I have a background in both public health and nursing as such. And right now I'm serving in the role of the Director of the Office of Family and Community Health, which essentially is the Washington State Department of Health's Maternal and Child Health Department or office. So this aligns well with that initiative that you are focused on around maternal and child health. I'll just share briefly about what it means to be a public health nurse in case you are not familiar with that. So, rather than being a clinician, my specialty in nursing is understanding disease and health as it relates to populations. So I apply the nursing perspective and practice to the health of large groups of people and of subpopulations. In particular, I focus on women and children. I have come to this particular position after many years working in public health and in nursing, and have been in the government or public sector for about the last 6 years. Prior to that, I worked in South Africa and Mozambique, and then before that, I was actually in South Los Angeles doing community-based work.
Awesome. Mozambique, that's interesting. I've done some projects through Rotary doing water well retrofits in Uganda up near Gulu, where the LRA had invaded the country. And
Wow.
then prior to that, we went to Ethiopia and did immunizations for polio, vitamin A, cataract surgeries, and water and sanitation projects. So there's a lot of need there, and I'm really pleased to know that you were there as well.
Yeah, I forgot to mention that I am the daughter of a lifelong Rotarian. My father was in Rotary for years, my entire childhood. So as you can imagine, we had we had international students in our all over the world. And I actually had a couple of Rotary scholarships to go for college. So Rotary is really close to my heart. I was kind of delighted that the request came my way.
Well, that's fantastic. Do you know what community or what club your father was in?
Yeah, he was most active in Redlands and Riverside. So we were in Southern California.
Okay.
And then in the Flagstaff area in Arizona.
Fantastic. In Arizona as well.
Yeah.
You hear that, Chuck? Down there in Arizona as well.
I did hear that.
Yeah, that's great. That's great. I'm so glad and I'm really glad you joined us tonight for the program. I'm hoping that maybe having seen a Rotary request is one of your incentives or motivations to do this tonight.
Yes, it is. I'm happy to share.
It's 7:06. It's a few minutes early, but let's go ahead and start, Katie, with the presentation. If others join, that'll be great. And Chuck and Jim and Jen, and I will also be ready with any questions as to how Jen's presentation may tie into something that the Rotary needs to be aware of or can take action on. So, Katie, it's all yours.
All right, great. Well, I am going to come to this from, as I was sharing earlier, truly a public health perspective. And some of this, because the four of you are very, you're really well familiarized with social and health issues, it might seem a little rudimentary, but I'm hoping that it'll still be insightful. So you might have noticed overseas and in the United States, ministries of health and departments of health, we always have maternal and child health programs. And I wanted to share a couple of reasons that at the Department of Health in Washington State, we focus heavily on maternal and child health. So we know intuitively and from science that health and adversity during especially the prenatal period and early childhood have profound effects on our lifelong health. That's one of the reasons that perinatal period is very important to us. An example of this that you might be familiar with is exposure to alcohol in utero, which for some individuals, though it's not predictive, can be linked to cognitive development and learning problems, which does have implications for schooling and employment in the future. So that's an example of that. One of the reasons that we focus on there is because this sensitive period for perinatal and early childhood. We also focus heavily on the pregnancy period because it is a time, unlike any other time in the life of a woman and a partner, if there's a partner involved, where we are sort of intrinsically motivated to be our best selves. And so we really emphasize supports during this time, especially for women that might be struggling with substance use disorder, or in a domestic violence relationship, or have other factors that are really negatively impacting the quality of their life. Pregnancy is a time when they are often open to change that they wouldn't be otherwise. So we monopolize on that, we attempt to. And then, early investments, we are not the best at this in the United States, but early investments really do pay off. So we know through many, many studies that investment in pregnant women, young families, and adolescents really bear fruit in our social services and our public systems. So at the Department of Health, we're really very cognizant of how we can maximize whatever funding we have to invest early. We try to focus on prevention as much as we can. And then you who have worked overseas, you've certainly seen this, that supporting women has positive impacts on everyone, both in the immediate family and in the community. So anything that we can sort of do to shore up the health and well-being of women, we see direct benefits in their families and their communities. So I wanted to just share a little bit about our perspective, the public health perspective on what affects maternal and child health. What are the things that we're really looking at? What are the main drivers? So we tend to think in public health of things that you're probably thinking of as well, really sort of obvious issues that are direct contributors to health. Some of those would be our readiness for pregnancy. Like we have a goal that we would not have unintended pregnancies in Washington State, that our pregnancies are healthy, women have access to prenatal care early on, that our babies are born at healthy weights and they're born at around the ideal time, that our infants, children, and adolescents are receiving the immunizations that they need to receive to prevent infectious disease spread, that all of our families have access to quality fruits and vegetables, and they live in neighborhoods where they can actually be safe enough to be active, and their schools support active lives. And then that all of our children and adolescents have medical homes where they can receive their well child visits. And in addition to getting sort of their physical assessments, as they get older, this is a main space, especially recently with the Affordable Care Act, where adolescents in particular are screened for depression, anxiety, and substance use disorder. So those medical homes are really important. There's a whole another group of drivers though, and you had already alluded to it, Bill, when you were presenting, that really the most profound influencers of health are what we called social determinants of health, and those are related to our socioeconomic and physical environments. And this includes things like education, poverty, financial resources, safe, affordable housing, a stable family, being in high functioning communities where there's high reciprocity, which basically is people returning favors back and forth. All of these things collectively are really large drivers of our health. And you can see from this little figure of a person that they comprise most of our health and well-being. The interactions that we have with the healthcare system directly is only attributed to about 20% of our health and well-being. A part of the social determinants of health includes biases, so institutional biases, and those would be biases, including biases around sexuality, abledness, like whether or not you have a disability, our gender, and our race. And those four factors tend to be the things that really, in addition to poverty, really drive the disparities that we see in health. So like all other things being equal, why is it that African American women have more low birth weight babies than white women do? When we control for everything else, we still see a difference in health outcomes based on some of those factors that I just mentioned. So in public health, we talk about these disparities being connected, like the one I just gave an example of low birth weight for African American women, that there's something actually about cumulative stress over time or allostatic load that really influences the health and well-being of a mom and her baby. And institutional racism could be contributing to that. And then a final area, and maybe you talked about it with Jen's presentation, but there is a lot of emerging understanding around the role that childhood trauma plays in our health and well-being over time. I'm going to just ask you guys, are you familiar with the adverse childhood experiences study and the Kaiser study? Is anybody familiar with that? Yeah. Okay, so Jen is familiar with it, and please feel free to add to this. But essentially in the public health world, this was one of the most profound findings in our understanding of health. It was almost like one of the most profound things since we discovered that antibiotics really can, antibiotics or vaccinations, it's kind of on that realm where there is sort of these distinct and predictable ways that at a population level, when you look at a large group of people and you look at the burden of child abuse, neglect, and then just unstable housing situations or household dysfunction, these are, when that burden is high, we see really specific negative outcomes and health over a life course. And I just want to emphasize, again, in public health, I look at population level data. So this isn't something that would translate one-to-one. It's not like I could say, because one person has a high level of childhood adversity, they therefore would have poor health outcomes. It doesn't actually work that way. It just works at, when we look at population level data, that's how it works. I have a child in the background squealing. I'm sorry, you guys. So there's 10 adverse childhood experiences, and they're basically, you can see here, it's a combination of physical abuse, 2 neglect areas, and then domestic violence, a parental incarceration, a mental health issue in a parent that is unmanaged, household substance abuse, and then parental separation or divorce. And it turns out that it is not so much that whether or not any one of these things has happened to an individual or a group of people, it is more the cumulative effect of these experiences that ends up having a really large income on our health over time. So I'm just going to give you one example of how this shows up. I have a lot of data, but I didn't want to kill you guys with data tonight. So this was just a report that was recently released about the state of adverse childhood experiences in Washington. And what I really want you to see is that left-hand column, just to give you a sense of increased risk for, you know, if you have 2 or more ACEs or 2 or more of those things that were on that list that I mentioned earlier, you can see that a child will have will require more routine healthcare visits, that they would manifest a developmental or behavioral problem. It might show up in overweight or obesity. It shows up in social environments with bullying and being picked on, engagement in school. The health of the mom is connected to it. That's not surprising at all. And then there are these factors that we track around resilience and flourishing in children as a state, and that goes down, of course, when the childhood home is a more is a less stable place. These are sort of immediate things that trauma influences in the child's life, and you may have talked about this with Jen's presentation, but there are many long-term factors that are associated with trauma during childhood, including all of sort of the inflammatory diseases. So if we think about heart disease and cancer and diabetes, and then certain mental health issues and certain high-risk behaviors are very heavily associated with adverse childhood experiences. Many of the more extreme ones, they're associated with individuals that have experienced a lot of trauma. So they might have 7 or 8 out of 10 of those adverse childhood experience categories. That was a really quick synopsis, but really just to say this is an area that when we're looking at the holistic health of communities, this is something that is really on our radar. And we're always kind of asking ourselves the question, how can we prevent child abuse and neglect, and how can we shore up families so that they have access to supports that would help prevent or mitigate domestic violence, incarceration, substance use disorder, etc. So now I'm just going to go into kind of some snapshot information, and I hope that this isn't too much. I actually did not incorporate a lot of data into this because that can just get overwhelming, and I will say I am happy to share any data with you. We have a lot of data at the Washington State Department of Health. So this is really just meant to give you an idea of what we're doing well and areas that we're worried about. So things that we track in my office, the sort of maternal and child health office, is we are doing well in breastfeeding rates in general, especially for women over the age of 25. We have over a 90% initiation of breastfeeding, which is high, and pretty strong maintenance of breastfeeding time, especially for that 5 and older year old. I know that you guys said that you were interested in vaccine coverage. We actually do have high compliance rates early on. We struggle a little bit later, and I'll show you that, but our coverage rates for infants tend to be high. Our maternal mortality, so that's a mom who dies during pregnancy the first year of life, and infant mortality, death during the first year of life for an infant, they are lower than other states. We're considered a sort of a best practice state in some of those areas. We have low rates of sudden infant death syndrome, also a best practice around reduced smoking and back sleeping, putting babies on their back. Our smoking during pregnancy rates are significantly declining. And Washington State is really generally seen as a supportive environment for women and children through our legislation, and we have really extensive programming across the state, actually. While there are gaps, it is considered a pretty positive place for women and children. Some of our challenges, I think, Chuck, you said you're from Gig Harbor. A lot of my photos are from Gig Harbor, actually, because that's where we live. So we are seeing a really steady increase in neonatal abstinence syndrome, which of course is associated with substance use during pregnancy for the mom, and this aligns with the increase in opioid use in our state, opioid use and especially heroin use recently. About 30%, so only 1 in 3 of our kids in the state receive developmental screening. And the reason that this is important is, of course, that is sort of the gateway to resources if you are a child that has any delay in development, and that delay could be really significant or it could be mild, but it's a space that we want to see dramatic improvement. The American Academy of Pediatrics recommends 100%. So, and of course that makes sense. 1 in 10 of our children live in homes where there are drugs being used in the home in some form. That includes alcohol. And in reference to our immunization rates, about 40% of our children aged 19 to 35 months are not fully immunized. We have a really specific schedule, which you are probably aware of, and we have low coverage numbers. If you are familiar with the concept of herd immunity, which is that rate of vaccination that has to happen in a community, in order to prevent the spread of disease, for a lot of the conditions that we are concerned most with, we need about 85 to 90% coverage. And then the last thing there is that our well child visit rate is increasing in the state, but it's still pretty low. And again, we use that as, that's really just a measure of healthcare access, and then kids and adolescents, infants, kids, and adolescents getting access to really important screenings, including developmental screenings, and as they get older, the depression and behavioral health screenings. We also see some pretty significant disparities, and I've only cited a few here. These are some of the things that are really heavily on our minds. So we have had the experience in Washington State where in a couple of areas where we rank really well across the United States in our rates, but when we drill down to race and ethnicity and poverty, we see real differences in the experiences, the health experiences of people. So I've listed some of the areas that we see differences by race. That includes infant mortality, birth outcomes, and by birth outcomes, I mean babies being born prenatally or low birth weight, child mortality, and then maternal mortality. Our smoking prevalence, especially during pregnancy, really varies by race. And then our prenatal care access is one of the main areas where we see a difference by poverty level. So our Medicaid births, so women that are enrolled in Medicaid have a lower early prenatal care initiation rate, and that ends up, of course, being really important for the health and well-being of mom over time, over her pregnancy. A couple of other big picture things just to frame what's going on for women and children in Washington State. Looks like I had a typo there, but about 20% of our children, that's supposed to say age 0 to 18, have a special healthcare need. And special healthcare needs can include something like hearing loss, deafness, blindness. It can be developmental delays. It can be learning delays. So it's really, it can be cardiac issues. Really, it could be a very, very physiologic issue, or it could be a cognitive development issue. That is a broad category there. But, 20% is pretty high if you think about 10 kids, 2 of them would have some kind of special healthcare need. About half of our children meet the kindergarten readiness domains, which means, half of them do not. About 50% of the babies in our state are covered by Medicaid. So that is, a proxy for, it's one of the best proxies we have for moms and infants that are being born into a relative level of poverty. We know that homelessness, especially among children, is rising rapidly. Our child poverty rates in the state are increasing. In some areas of the state, it's almost doubled in the past couple of years, and we do see disparities by race and sexuality, especially when we get into adolescence, around youth homelessness. I know that our homeless rate is not necessarily significantly worse than other states, but we have a really significant problem with affordability of housing. Over 50% of women in our state are overweight or obese. And I really just bring that up to say that there are some health conditions during pregnancy, especially gestational diabetes, that can be really complicating for a woman if she is struggling with overweight or obesity. And sometimes this is just an indicator that women don't have, that they have high stress levels and they don't have access to healthy fruits and vegetables. And then 20% of our children have high trauma exposure during childhood. That's actually 2 or more ACEs. So again, if you looked at that list of 10, about 1 in 5 or 2 in 10 of our kids would have on that list, they would have at least 2 of those 10 items and or more. So this is actually my last slide, and then we can just open it up to conversation. And this is not comprehensive, but I just wanted to highlight a couple of things that our agency is doing. So we just received a legislative support funding to develop a statewide universal developmental screening program. And remember, I said only 1 in 3 kids receives a developmental screening. This is a way that we would have like almost a registry of children that are being screened. Parents would be able to use this system, and we really want this to be a portal to connecting, first of all, increasing screening, and then connecting kids that screen for a health issue, a special health care need, or a developmental issue, a way to connect them with resources that would be supportive of the child. Also, by statute, the legislature in the state has supported and funded a maternal mortality review panel. And this is a very diverse sector of professionals and paraprofessionals that review every death that happens to a woman in Washington state during pregnancy or postpartum, 1 year postpartum. That does include a coroner's examination. And so those are very comprehensive reviews. And our goal there is to identify preventable maternal death. And then from there, every preventable maternal death that we review in detail, we look for commonalities and figure out what are things that we have to change in our system to make sure that women are not dying unnecessarily. And we've had some really excellent applications from those recommendations. We have a really strong children with special health care needs program, including the screening and diagnosis and connection to resources. Washington State has a breastfeeding friendly hospital initiative, which is, some of you might be familiar with baby friendly hospitals. That is like the panacea of hospitals that promote breastfeeding. It's a really hard thing for hospitals to achieve. So Washington State has sort of a midway point that it supports hospitals in becoming breastfeeding friendly places. And we already see the way that this is improving breastfeeding rates in the state. I already mentioned that we really focus heavily on home visitation support. That would include programs that are considered evidence-based for child abuse and neglect prevention. We fund all of our local health jurisdictions to some level. There's 35 local health jurisdictions, and the vast majority of them use our funding to do some type of home visitation in their communities. We have a maternal opioid project where we're working with hospitals and health systems. Actually, I'm just going to say the health system, to increase the number of bedding in units in the state. That would really just allow women who have opioid addiction to, rather than losing their child at birth, to actually go through treatment with their child in a heavily supported and safe place for them to be together. And then the last 2 here is we take surveillance really seriously. And so I said that we have a lot of data, we really do. Surveillance is a way, of course, that you pick up on things that you wouldn't see one-on-one, right? Like you might not see it in a small group of people, but you start to see trends in large groups of people. And that's really important for tracking what's happening at a population level. And then although we don't, as an agency, our charge is not to address homelessness or workforce development or employment opportunities, or even largely, we're not like the child welfare system, or we're working around child abuse and neglect prevention. We partner very intentionally with other agencies and community partners to address the social determinants of health and childhood trauma. And I have many examples of those, but just to say that that is one of the ways that we in my office do work to promote maternal and child health. So that was what I prepared. I think, Bill, you had asked for about a half an hour of material and then just letting people have conversation if people had questions.
Thank you, Katie. I made a whole page of notes and I have a lot of questions, but I don't want to be the one that dominates. So what we're going to do is we'll start at the top of my screen and we'll go down like from Jim to Jen to, and I don't know why Sasha is down there as Maria, and then Chuck, and then I think that's Dell Livingston down there at the bottom. So Jim, do you have any questions or observations for Katie?
Not at this time. I'm just learning the Washington system. So
Okay. Even if it's not island related, do you have any questions about programs or issues that Washington's facing, or why one issue might be larger than another?
No, not at this point.
Okay, all right. I know Jen does, because Jen's our youth protection officer, and I'm sure when that A screen came up with all those home factors, I know that I was watching Jen eyes open up. So Jen, go ahead.
Oh, I was going to say about that ACE. We actually have a Rotarian that goes around and speaks about that ACE test. And I heard his talk on it and looked into it a while ago. And it is a very interesting test to take and to have your friends take and to see how true that is. That is a very, very interesting and eye-opening. I just didn't know that it was as, what did you say, like revolutionary as you said it was?
Yeah.
Yeah.
Yeah, Jen, one of the things that, like, I'll just give you guys an example. So that was eye-opening to us in public health was that, and you guys will have to forgive me, I think it is 6 or more adverse childhood experiences. So again, this is at a population level. This doesn't mean anything about any one individual. But like the cancer prevalence in the group of people that self-identify as having 6 or more of those experiences, 20% of cancers are connected to that, which is sort of surprising, right? Like you wouldn't think the risk for cancer increases at a population level because of childhood trauma, but we saw that. The other one that we saw at the time that the Kaiser study was done, one of the things that virtually never happened unless there was a history of childhood trauma was injection drug use. Now that has changed since we've had the prescription monitoring program, and opioids have been heavily monitored, and heroin is sort of an opioid replacement. But before that happened, injection drug use was it was almost solely related to an experience of childhood trauma, which really said to us that there was something there's some connection between childhood trauma and what is happening in the endocrine system, like the system that's moderating the wellness, your sense of well-being, and your mental health that is heavily affected by trauma. And there's a lot of coping that goes with that. And injection drug use was one of them. I don't know if that made sense. Those were just 2 things that I remember when the study was first coming out in public health. They were like, oh my gosh, other than smoking, there's nothing else we know of that is so heavily connected. Or, I mean, there's a couple of other carcinogens, but there's nothing else that is so connected with cancer prevalence. So anyway.
And I'll just say one thing about that and then let other people talk. But I just find that fascinating because there's so much that we can do as a community, and there's so much we can do as Rotarians to help children in our communities.
Yeah.
And should we be able to help them mitigate against adverse childhood experiences, perhaps we will make our lives better in ways we cannot even imagine by just doing, something.
Yeah.
Anyway, that's all I've got to say.
Well, Jen, you're right on. I mean, a couple of the clubs in our area help sponsor programs for safe housing for families. And I'll go into some of that later. But Sasha, I don't know why you're incognito with Maria there, but do you have any questions? Oh, by the way, Katie, Sasha is coming to us from Japan.
Oh, hi, Sasha.
Hi, Katie. It's because I do some trial English lessons online sometimes, and to do that, I need an easier name to say than Sasha, apparently. So it's very easy for them to say Maria over here. Thank you so much for the presentation. I'm sorry I was a little late. The time change often is confusing for me. But I was taking some notes in the background just so I can put it on the Slack channel. I thought the information about the children from minority mothers being born underweight, I had no idea that was a thing. You'll have to forgive me because I'm Canadian, so our systems are a little different. But I was wondering what is being done to kind of countermeasure, like, is there any way of predicting that a person of minority who is giving birth to a child, like are they given like resources or nutritional advice, or what can they do to countermeasure possibly having a child that's severely underweight?
Yeah, thank you for that question. So that is one of the areas that we work really hard around. And it's low birth weight and infant mortality and maternal mortality. Those are all things that we see differences between American Indians, Alaskan, African Americans compared to the white population. The things that we know is that there are things that happen at the point of care that we think are connected, especially to infant and maternal mortality, and they're subtle. They're subtle things, but they're things that the systems have identified. So I guess I would say that some of the things that we're doing to really try to practically address it is, one, really raising awareness about specific situations that happen. So for instance, like this is maybe an unusual example, but we know that African American women are more likely to seek care from a provider that looks like them or has their background experience. So for us, just being really aware of how can we improve the healthcare workforce so that it's representative of the communities that are served. We hear a lot from community about things like Black women, their pain not being taken care of seriously, like when they're during the postpartum period, or a family advocating for, let's say, a wife has just given birth and the husband advocating with the healthcare personnel that something's wrong, like his wife doesn't look good, there's something wrong, she needs care, that woman might not get care as quickly, or the spouse wouldn't be taken it seriously. So these are we call that institutional bias. They're not at the fault of one person. People aren't doing it on purpose, but people are, you've seen it with the law enforcement, that there are just ways that we have become biased as a country over time, and our institutions really show that. So the ways that we combat that actually are by working with hospitals and healthcare systems to make sure that they always follow set procedures, that it doesn't matter who the patient is, they're just actually following a checklist. And that seems like that would have already happened, but in a lot of ways it hasn't. And when we create very specific clinical pathways that nurses and physicians are just trained to follow, really disparate. I don't know if that makes sense, but
okay, no, that's really interesting. And like I said, our medical systems are a little different, and especially because I'm from Victoria Island, we don't actually have a very large Black population at all, but we do have a lot of Indigenous people in our community, and I had never really thought about the impact of their lives affecting pregnancy, which should be obvious, but I just think that's a really interesting and a really good thing that you're doing to try and counteract. So thank you.
Yeah, thanks for the question.
Great. Thanks, Sasha. Chuck, how about you, sir? Questions or observations?
Well, I have two general questions. First of all, if you watch the news, you see in great parts of the country, women's access to Planned Parenthood and their right to terminate pregnancies are being limited. And where are we in Washington on that issue?
Yeah, that's such a good question. So this was one of the things I was alluding to that were considered sort of a better place to live for women's health than other states, because our legislature has very strong bipartisan support for full reproductive care access. By Washington state law, we actually are required, all healthcare providers are required to offer women a full range of safe and quality service options across the continuum, and that does include abortion. If they are interested in abortion, we provide safe and quality service recommendations for them. In our state, we have had to, I guess I would say, we've been forced into a situation where we can no longer take federal funding, the Title X funding, and that is because our Washington state law is in direct contradiction with the federal regulations around how that funding is used now. So in our office, we're actually bringing forward a decision package. That's, you guys might know, but that's what we call a request of the legislature for funding. We're requesting that our legislature makes up the difference in the family planning dollars that we would receive from the federal government. And it looks like they're going to, and it's not just abortion services, of course, that are covered. It's like the full gamut of services, reproductive health services that are shortchanged because of the way that the federal rule is written right now.
So the 14-year-old girl who's pregnant has recourse in this state?
In our state, yes.
Okay. My second question kind of goes, you mentioned several times about our homeless population, and what specifically, can we do and what do we do to assist the people who are homeless and who end up pregnant and who may have the baby? I mean, what do we do about these babies of homeless people?
You're asking the $1 million question that we had a meeting about today, actually, with several state agencies and nonprofits. So we aren't doing a good job of supporting pregnant women in Washington state, pregnant women who are at risk or are homeless. In Washington state, we don't have set-asides for priority housing for pregnant women. So that's one of the things that we're really trying to work through. Like, is there a way, for instance, is there a way that we could allot some of our housing vouchers to be for pregnant women, and including pregnant teenagers and women who have a substance use disorder? Is there a way that we could prioritize housing for them? And I would just say it's something that I would love to share more information with you as we kind of explore it in the next couple of years. We actually
do we have newborn babies out on the street?
I can't say yes or no to that. What I can share with you is that I haven't seen data specific to infants, homeless infants. I do know that the community level, there is people are very responsive to infants being on the street, infants and young children, especially that 0 to 5 age range, which is not to say that we don't have any homeless infants. It isn't, what I hear more of or what I see more of in the data is school-age children and teenagers. Homelessness in those two populations, especially for teenage boys once they get to a certain age, because they can't, they're not admitted to the shelters with a parent.
Katie, follow up on Chuck's question about trying to find, especially homeless babies in the community. Does Washington State Department of Health have any sort of an outreach program as far as like some cities do, actually going into homeless communities and doing on-site survey?
So we don't, are you talking about surveying of the number of people that are homeless, like the point in time count?
Well, I'm thinking about being even more specific, going into, especially in large population centers, Tacoma, Seattle, where there are known large homeless communities, actually going in there with a representative from the Department of Health and actually going literally from shelter to shelter to see if there are moms and or babies in need?
We don't do that.
Oh.
We don't do that. So one of the things, and I didn't explain this early on, but an interesting way that the Washington state is set up is that most of our public health happens actually at the local level. By law, counties are required to support a local public health department. So in Washington, we have 35 counties, and I think we have 33 health jurisdictions. So there are some health jurisdictions that are more involved locally in going in. But to be honest, I don't know how many of them are, I don't know of any of them that are actually doing what you just said.
Okay.
There are definitely public health departments that go into like tent communities or squatter communities, I guess I would call them, and do like some surveillance. So they'll do a point in time, like how many people are living outside in any given night. And they do much more from the environmental health side. So sanitation, do people have access to clean water, toilets, that kind of thing.
Okay, that's a good answer. I mean, it's a different answer than I was expecting, but okay, this is local communities. So I want to, Chuck, if you don't mind, I'd like to bounce down and see if, I think that's Dell. Dell is one of our members who works in Kenya 6 months a year. Dell, can you hear us? And do you have any questions?
Am I on okay?
Yes, sir, you're perfect.
Oh, okay, great. Yeah, it's very interesting because you're covering a lot of territory that's never even thought of over where we live over there. But the different departments are trying to do a good job, but Washington State is way, way ahead. It's just amazing. My interest in kids and so forth, of course, has been foster care. And that's one of the biggest issues we've had to deal with over the years. My wife and I had 23 foster kids, and they came in different varieties and different problems as far as that was concerned.
Yeah. Well, you were working with children that had high trauma experiences for sure. If you were you in Washington?
Washington and Oregon.
Yeah.
Yes, we were, very high trauma situations.
Yeah.
And we spent a lot of time going to the prisons with the kids and so forth, which was a big deal.
You know, Del, you might be interested that, I don't know how much actually this is of interest to you, but there's a lot of work right now happening at the state level across sort of child welfare, Medicaid, which is the low income, insurance. Well, your kids would have had Medicaid. Your foster kids had Medicaid.
Yeah, they were all covered.
Yeah.
And
Medicaid's doing a lot right now to try to figure out how to care for foster kids that they call them foster kids with complex needs, which is kind of ironic because every foster kid has a complex need. But what they mean by that is foster children that have both a developmental issue and a behavioral health issue. So they might have they might have mental illness and a learning disability. Though they tend to be the kids that are really hard to place. And in our state, they end up sheltering in motels. And they've actually been directed by the state legislature to essentially solve that problem because no child should be living in a hotel or motel overnight. So if you're interested in learning more about that, I'd be happy to send you some information.
yeah, sure, because I know it's a growing problem, and we did an awful lot of work with psychiatrists and so forth over the years.
Yeah.
So Katie, if any of these questions come up, if you have resources for those, if you could send them directly to me,
Sure.
then I can assemble that in some sort of an organization and then email it out to all the club members, including those who weren't on tonight, but we'll look at the presentation later. But so I was going to mention, I looked at those 10 situations that are likely to cause problems for children. And I was a foster child. And initially I was in terrible situations when I was younger. And the intervention came when my adoptive parents finally found me. I was considered non-adoptable. I had quote unquote developmental educational deficiencies. But once my environment changed, and once I was in a home where people cared and loved for me and took care of me, it changed, literally changed, I imagine, to me it was like overnight, but probably within a year, and I was back on track. And I think intervention, and I don't know how Department of Health works with that, but do you coordinate with CPS or anybody like that for intervention services?
Yeah, well, first of all, thank you for sharing your story. You are a perfect example of why I kept emphasizing that you can't take this information at a one-to-one level, because everybody is really different. And I only showed part of the picture because the other side of trauma is resiliency and protective factors. And actually, Jen, you mentioned it, but like all of the things that we can do in community where we're connecting kids with mentors, or we're making sure that foster children are placed in safe homes. We have after school programs, we have quality teachers, like all of those things end up having a really, really significant impact on mitigating trauma. So there are so many experiences like yours, actually, which are remarkable. Yeah, we do quite a bit of work. One of the things I probably should have shared early on is that at the state level, most of what we do is on the policy and system side. So instead of working one-on-one with families, like for instance, working on placement with a particular community of high-risk kids, for instance, we sit on the end of the policy side. So like, or system side. So like, what is happening in our state that we have families that are incapable, moms and dads that are incapable of caring for a child? What are the things that are going on for them? How can we intervene or prevent that from happening? What are ways? And I mean, that could be, there's so many examples. One example could be, we do a really terrible job of streamlining our public benefit systems. Navigating the systems, our systems, is so stressful and overwhelming for people. It takes away from their ability to care for their families, takes away from their ability to work. So we're looking at where are there ways that we can have like a single application system where your application for Medicaid is the same as TANF, is the same as workforce development, is the same as your free lunch application, is the same as your Section 8 housing application. Like, are there ways that we can streamline that? So that was just one minor example, really just to say we do work on it, but we are at the big picture level.
I understand that policy and systems.
Yeah.
I have a couple questions for you, so I don't want to take too long, but you were talking about, numbers and percentages, and of all those percentages, 20% and 10%, what do those translate into actual numbers of children, numbers of mothers?
Yeah, that is such a good question. So I would have to send that to you because they're all different.
Okay.
And but I can send you like, for instance, I cited like the number of children with special health care needs, the number of children, or the percentage of children that have 2 or more adverse childhood experiences. Those things we do have the number of children. We have the estimate number of children. The thing I'll just share with you that is most helpful for me when I look at numbers is I often break it down into a classroom size or a group of 10. So when anything that's a child indicator, I think about a classroom of 25 kids. If I were a teacher and I have 25 kids, how many of those kids would have adverse childhood experiences? How many of those kids would not be fully immunized? So for me, that's a helpful way to think about it, but I am happy to share.
That would be really great. Rotary has this thing. I went to a program once where a speaker talked about, and it reduced the community in the world down to 100 people.
Oh yeah, I've seen that. That's
you ever seen that one? Yeah. And then he profiled gender, ethnicity, race, health conditions. It was amazing. Yeah, it was amazing.
We would all be in the top 1% because we have a computer.
Yeah. So just some observations for you, just to give you some education on what Rotary does. There's a program in Olympia area called Rapid Rehousing. Have you heard of that?
I have, yeah.
Excellent. Okay.
I'd love for you to share more about it. Yeah.
Okay. Anyway, I won't go into detail right now, but the Olympia Rotary Club actually had several of their members trained to be mentors in that. And they worked with Thurston County Housing Authority and with an organization called Sidewalk to put families as quickly as possible back into housing, apartments. They furnished apartments, they provided clothing, et cetera, to keep that family intact and to keep the children on track, for education and health. There's a clinic in Centralia called Hope. It's called the Hope Clinic. Actually, the doctor's name is Hope, and they work on, they get donations from the Rotary Clubs down there, and they provide free vaccinations for families in need. And there's a program in Puyallup, I noticed in your ACE program about bullying, there's a program by Rotary Clubs in the Puyallup area where they actually do education in grade school, middle school, and high school on bullying, how to combat bullying and to improve children's lives. So I guess I am going to open up the floor in case anybody else has a last minute comment or question, but if from your observation and having a Rotary background with your dad, in all the areas of like education, awareness, actual physically doing something in the community, what do you think Rotary could do that would have a positive impact?
Thank you for that question. You guys are amazing. Like I said, I love Rotary. The thing that I think Rotary is so strong at is being embedded in community and doing the soft touch things in people's lives. It isn't, so what I mean by that is all the examples you just gave, supporting local initiatives and nonprofits that are working directly with community members. It's so important. It's hard for us to quantify it. I mean, like I said, I always work at the population level. I'm always at the big picture level, but when we talk to people, that it is all of those things that happen in community that make the most profound difference for them. So I think just continuing to invest in local community initiatives is so important. And I will just share one more thing with you. We just finished a survey of women. We did a community survey across Washington State and just asked all over the state, what is it that we need to do to improve the lives of women and children? And I'll just share with you what we heard. And I think maybe it's something you'd want to think about as you're making your decisions. So the top things that came up were housing, stable housing, affordable housing, eviction prevention, even, we don't do this much in the United States, but even cash or direct checks to landlords to prevent eviction, because eviction is so incredibly traumatizing. If we can just keep people housed, we are winning a huge battle. The other thing was affordable childcare, especially for people that don't qualify for early Head Start and ECAP. Those are all low programs for low-income families, but the families that make just above that, which is still not even often a living wage, it's very hard for them to afford childcare. And then communities that have a lot of supports for families and parents. So that really is picked up by the child, by the school system and the nonprofit system. So that's what community said was the most important things for them in improving maternal and child health. It isn't the things that we at the state level spend a lot of time on, but it's what they said.
Thank you. I wrote all that down. That's great input. I appreciate that. My wife belongs to a Rotary Club in Tumwater, and I may see if I can't see if you could make the same presentation to their club. They're also very active in the community. So yeah. Before we end, and Katie, I want to thank you. This has been a really, really informative program. I want to go back down the list and see if anyone else has a last minute comment or question. So Jim?
I find this whole conversation very interesting.
Yeah, it is really educational, wasn't it, Jen?
A lot of things I can pass on to us Canadians up here.
Yep. Jen?
I'll unmute myself here. Thank you so much for speaking with us today. I really appreciated hearing your whole presentation. It was great. Thank you.
Okay, Chuck?
No, I'm good. I wish I had invited my wife to see the presentation. I'm sure
Yeah.
she would have enjoyed it.
And by the way, members, anyone is welcome to sign on. Family, friends, anybody who wants to sign on to our meetings is welcome to. Dell, anything?
Well, I'm really appreciative of this conversation because there's so much that we don't know about what is going on in the state. We just hear the superficial things that hit the news, not the people working on the street with all these issues.
That's a great comment, Dell. Thank you. And Sasha? I guess we lost Sasha. Okay. Katie, do you have any last comments, or do we just say thank you and good night?
Well, I just want to thank all of you and just say it, at a personal level, it is very special to me to see especially you men, because you're reminding me of my beloved dad. And so I just thank you. Thank you for what you're doing. Thank you for investing in community and each other. And best of luck to you guys as you're doing good work.
It's our pleasure. That's why we belong to Rotary. Service above self. Well, Katie, again, one more time, thank you so very, very much. And I do appreciate it. And I will refer this program to other people. I think this is this would be a tremendous thing for other Rotary clubs in the immediate area or around the state to hear. So thank you so very much.
Thank you. Take care.
Okay. All right, everyone. I'm going to click the end meeting button. So good night, everyone.
Good night.
Hi.
Great program. Bye-bye, everyone.
Hi.